Right, I'd like to welcome everybody to Refresher Course 1109. This is on gynecological and obstetric hemorrhagic emergencies. I'm Anna Maria Belli, and I'm chairing this session. It's an interactive session, so I'm going to give you a little brief introduction. Then we have 3 speakers, and then after this we'll have a panel discussion when we will talk about radiation protection. But I would like you as the audience to please feel free to get up and ask questions. Perhaps not always on the panel discussion. You may be free to discuss other things as you wish. Now, having a baby, for most of the women in the audience who've had babies, this is usually an incredibly pleasurable time. It's a moment of great happiness for mother and father alike. But just occasionally, it's a very traumatic time. Obstetric hemorrhage is still a problem in our Western world. It's not just confined to third world countries. And if we look at the evidence so far, we can see that postpartum hemorrhage complicates about 10% of live births worldwide, and it accounts for about 1/4 of all maternal deaths every year throughout the world. Now, in the UK, we think we're pretty civilized, but we can see that there's still 2/3 of our cases of severe maternal morbidity are related to postpartum hemorrhage. And death from postpartum hemorrhage, we hope, should never occur. It's one of the events in our institutions that's supposed to never happen, but unfortunately it does. And for every death, there are about 60 peripartum hysterectomies, which means that those women have bled so severely that the surgeon feels that they have no alternative but to do an immediate hysterectomy to stop those women from bleeding. So there's quite a lot of problems associated with it. Now, in the UK, we had a healthcare commission looking at a series of 10 women that died over a fairly concise period of time in one of our major London teaching hospitals. And these people looked at the reasons why these women died and came up with this recommendation for the whole of our nation, recognising that interventional radiology has the potential to save women's lives, and recommending that all obstetric units consider setting up some form of network with interventional radiologists, either in the same hospital or, if not geographically located, with your nearest one, to set up systems, protocols, so that if a woman bleeds after giving birth, you can channel them straight to an interventional radiologist to consider embolization if you have time to do so. And this really set up a very good dialogue with our obstetric colleagues. Up till then, people were saying, oh yeah, we know you're there, we'll use you if we have to, but we're often leaving it a little bit too late to refer to us. And suddenly we had all our obstetric colleagues coming to us and saying, we must have protocols for this. So it engaged them. Another inquiry looking at the reason for maternal deaths in the UK came up with some sort of phrases which I think are of interest. One is that many of the women who do die from postpartum hemorrhage is because they are left to bleed and perhaps not enough is done early enough in their management to prevent hemorrhage. And as an interventional radiologist, and we do have a gynecologist and obstetrician speaking here who may challenge me on this, certainly it was my perception that women were being referred to me, or I was being phoned about these women, very late in their management, and sometimes just far too late. They also said that they felt that over-treatment causes less harm than under-treatment, which is an interesting concept, because normally we don't want to over-treat, but I think in the field of hemorrhage, that is probably correct. We should. So we have 2 speakers talking about obstetric hemorrhage. Obviously, as interventional radiologists, you understand the response of interventional radiologists to somebody who is hemorrhaging. But there is another role that we can play, and that's in prophylaxis. There are certain groups of women who are at high risk of hemorrhage. If those are identified before they go to caesarean section or birth, then we can take measures to actually reduce or prevent hemorrhage completely, and our gynecologist, guest speaker, is going to talk about this. But our first talk is on gynecological hemorrhage, and this is a different group. It's a much more mixed bag. I suppose we'd say that fibroids, adenomyosis very rarely cause such significant bleeding that it's an emergency, but I have come across women who have had to have it done in emergency situations from fibroids. Arteriovenous malformations, navi fistulae, very difficult sometimes to treat. If they're small, they're easy. If they're large, because they've been there for a long time, they can be extremely difficult for interventional radiologists to treat. And of course, cancer as another cause of hemorrhage. And our first speaker is going to talk about these things. And then we'll have a panel discussion on how radiation doses can be reduced, because we are treating potentially a young fertile group of women who may want to go on and have more children. And I think we really do have to consider radiation dose, even in the context of massive life-threatening hemorrhage. So I'd like to invite our first speaker, Dr. Pellerin, who's going to talk about gynecological hemorrhage, the etiology and the management. Thank you very much.